Hello, good day. My name is Dr. John Day, and my presentation today is, should the goal be AV node ablation with CRT or atrial fibrillation ablation in the heart failure patient with atrial fibrillation? And I should clarify this, that this is for the heart failure patient with medically refractory atrial fibrillation. So, medically refractory atrial fibrillation and heart failure, what's the best option? AV node ablation and CRT or AF ablation? My disclosures are listed here. In this slide here, we can see an interesting subset analysis of the AFFIRM trial, which looked at rate versus rhythm control strategy for atrial fibrillation. And I think the thing that really stands out here is that those patients with heart failure had a significantly increased risk of mortality in this trial. And I think it just really highlights the importance that atrial fibrillation and heart failure can be a very dangerous combination. This next slide takes us through the INTRINSIC RV trial. The INTRINSIC RV trial was a trial that we published in Circulation a couple of years ago, and it was a trial designed to look at what is the best programming strategy for heart failure patients with ICD indications. These are standard ICD indications. VVI 40 versus a DDD mode avoiding RV pacing. But this study that we recently published in Heart Rhythm really got at the point is, what is the impact of atrial fibrillation in these heart failure patients? And from the INTRINSIC RV study, we have 4 graphs here. The first looking at death, and the total study enrolled 1,530 ICD patients with heart failure. You can see that those patients with a history of atrial fibrillation had a significantly higher and statistically significant increased risk of death. Higher rate of heart failure hospitalizations. Looking at the combined endpoint of death or heart failure hospitalization, once again significantly increased if there was an atrial fibrillation history. And then also first ICD shock. And so once again, the take-home message, atrial fibrillation and heart failure is a difficult combination which results in a significant impact to the patient when looking at long-term outcomes. When we broke it down a little further in analyzing these patients from the INTRINSIC RV study, is we wanted to look at what is really the impact, what is the problem with atrial fibrillation and heart failure? Is it the rapid ventricular rate, or is it atrial fibrillation in general? In this study, you can see here as we presented, in the yellow are patients with no history of atrial fibrillation, in blue, those patients with a history of atrial fibrillation. And we stratified the likelihood of hospitalization based on heart rate. And you can see that from this, that even in patients who had a controlled ventricular response, there was a significant increase in heart failure hospitalizations if you had atrial fibrillation. And then if the ventricular rate was not well controlled, that risk of heart failure hospitalization was increased further. When we looked at the combined endpoint of heart failure hospitalization or total mortality, once again a similar situation, that regardless of the ventricular rate, there is a significantly increased risk of heart failure hospitalization and mortality with atrial fibrillation, and that becomes certainly more pronounced with the rapid ventricular rate, but once again seems to raise the question that atrial fibrillation and heart failure is a bad combination regardless of whether there is adequate rate control or not. Well, what about the role of AV node ablation in heart failure? And going back from the PAVE study, which was published a number of years ago in JCE, looking at what is the best pacing strategy if an AV node ablation occurs. And so the entry criteria is listed here. There were 305 patients. They all had chronic AF, which was defined as AF persisting greater than 30 days. And they had medically refractory rapid heart rates with atrial fibrillation. And so looking at the role of AV node ablation within these patients. The baseline characteristics are listed here. Average age, 67. For those who received right ventricular pacing, 70 for CRT. The ejection fractions are listed here. And there really was no difference with structural heart disease, medications, etc., in comparing the two groups of those who received right ventricular pacing versus those who received CRT pacing. Looking at the 6-minute walk, you can see it's stratified here based on ejection fraction. If the ejection fraction was greater than 35%, there really was no significant difference as to whether the patients were randomized to a right ventricular pacing strategy versus a CRT pacing strategy. However, with those patients with a left ventricular ejection fraction of 35% or less, there was a significant difference in exercise capacity of those patients randomized to CRT versus those randomized to right ventricular pacing. And when looking at the ejection fraction, you can see that those patients randomized to CRT, that the ejection fraction was stable throughout the course of the study, as compared to those randomized to right ventricular pacing. And I should mention that these were primarily right ventricular apical pacing, that there was a drop-off in the ejection fraction over time. And interestingly, there was no significant improvement in the ejection fraction despite being able to treat these patients with medically refractory rapid heart rates with their atrial fibrillation. So an interesting study was published in 2006 in JACC, looking at the 4-year efficacy of cardiac resynchronization therapy on exercise tolerance and disease progression. And really what this trial got at in their conclusion is that AV node ablation and CRT is similar to sinus rhythm in patients with heart failure. The baseline demographics are listed here. You can see 511 patients in the sinus rhythm group, 162 in the AF, looking at the age, New York Heart Association status, ejection fraction, QRS. So the crux of the study is really borne out here in this slide, where they looked at 3 groups of patients. You can see in red are those patients in sinus rhythm with CRT, those with AF ablation, those with atrial fibrillation and AV node ablation, and those with a CRT device and atrial fibrillation but no AV node ablation. Interestingly, when you look at ejection fraction, you can see that the green and the red line, or those with sinus rhythm or AFib with AV node ablation, seem to have the best ejection fraction, looking at functional capacity as well as echo criteria of left ventricular and systolic volume change. And so really drives home the point that in patients with heart failure, that at least from this study, AV node ablation CRT appeared to be equivalent to sinus rhythm. This is a study that's going to be forthcoming in Heart Rhythm, and the print version has appeared online, looking at AV nodal ablation predicts survival benefit in patients with atrial fibrillation receiving cardiac resynchronization therapy. And this was from the Mayo Clinic and several centers in China. The baseline demographics are listed here. Interestingly, when we look at AV node ablation, appears to improve survival with CRT. And you see there are 2 groups. There are those who received an AV node ablation with their CRT device. There were 45 in that group. Those who received an AV node, those who did not receive an AV node ablation but had a CRT device, and there was a significant improvement in survival from overall mortality as well as survival from death, heart transplant, or LVAD in those patients who received AV node ablation for their atrial fibrillation as compared to those who did not receive an AV node ablation for treatment for their atrial fibrillation. So what about the role of AF ablation in heart failure? An interesting study published in 2004 from the New England Journal of Medicine from Hasegawa and the Bordeaux group, where they had 58 patients with an ejection fraction less than 45%. The ablation approach was pulmonary vein isolation with or without additional ablation lines with 12 months of follow-up. Interestingly, when you looked at the echo parameters of LV and systolic diameter as well as ejection fraction, that there was a significant improvement in these atrial fibrillation patients if you could successfully eliminate the atrial fibrillation with a curative catheter ablation procedure. Those data were repeated from the University of Pennsylvania group. Similar setup, 67 patients, ejection fraction 50% or less, a pulmonary vein isolation approach with 6 months of follow-up. Interestingly, the baseline ejection fraction was obtained within 24 hours of the pulmonary vein isolation procedure in sinus rhythm to try to make sure they had an accurate baseline ejection fraction assessment in these patients. As we all know that oftentimes in atrial fibrillation with a rapid ventricular rate, we may not have a correct assessment of the ejection fraction. In looking at this, regardless of the echo parameter, whether it's left atrial size, the left ventricular size, that there was a significant improvement in the ejection fraction if atrial fibrillation could be successfully eliminated in these patients with an atrial fibrillation ablation procedure. Our data is listed here, and interestingly, at least when we look at overall success rate from our experience at 1 year, 85%. However, in red, we see that patients with an ejection fraction of less than 40%, that drops off, but still a 1 year success rate off antiarrhythmics of 71%. When we break this down based on BNP, interestingly, those with a normal or near normal BNP had a very high 1 year success rate. You can see at 91%. However, as you take it out in the purple bar, which represents those patients with a baseline BNP of greater than 1,000, that the success rate drops off significantly. So I think the take-home message here is that, at least from a success rate, that atrial fibrillation ablation appears to work quite well in the heart failure group, not quite as well as those patients without heart failure, but still very favorable 1 year outcomes. However, at least in our data, when the BNP gets out beyond 1,000, that this perhaps represents the patient with decompensated end-stage heart failure, and the success rate, certainly at least in our experience, drops off significantly in those patients with a very high BNP. Well, what about the role of AV node ablation versus AF ablation in heart failure? And there's been one study, it was a pilot study that was recently published in the New England Journal of Medicine, displayed here, pulmonary vein isolation for atrial fibrillation in patients with heart failure. And the baseline characteristics are listed here. You can see 41 patients in the pulmonary vein isolation group versus 40 in the AV node ablation by AV pacing group. Age 60, the ejection fraction was under 30%. What was the success rate with this? The success rate seen here, you can see that pulmonary vein antral isolation with or without lines or cafe ablations, the 3-month success rate nearly 80%, 6 months including medications near 90%. However, the 6-month success rate with no antiarrhythmics was a little better than 70%. However, they did note significant atrial fibrillation progression in the AV node ablation CRT group. And then also, interestingly, in the study, they observed no significant complications in AF ablation within their heart failure patients. When they looked at ejection fraction, you will see there was a significant improvement in the ejection fraction with pulmonary vein isolation versus those who received AV node ablation and BiV. Interestingly, in those who received the AV node ablation BiV, that the ejection fraction remained stable, there was no improvement, and this would be similar to the results that were seen in the PAVE trial. 6-minute hall walk, functional status similar. Those who received the pulmonary vein isolation, there was a significant improvement. AV node ablation BiV, we did not see that type of an improvement. So what are the conclusions from this? I think what are the take-home points? AV node ablation with heart failure may benefit more from CRT. And so that's something certainly to take into account. The outcomes with AV node ablation and CRT appear to be quite favorable. Atrial fibrillation ablation procedures in heart failure appear to be safe with significant improvements in the heart failure status. So really bringing us now back, what is the best approach for patients with medically refractory atrial fibrillation and heart failure? I think this is really institution or geography dependent. My answer to this question would be, if you are at a center that is very skilled and has a lot of experience with AF ablation, then I would argue that a potentially curative AF ablation procedure should be tried first. If that's unsuccessful, then down the line one could look at AV node ablation, CRT. However, if you are at a center where you do not have this expertise and there are no nearby centers where patients could be referred, then perhaps in a situation where the expertise is not readily available from a geography standpoint, that perhaps AV node ablation could be attempted first with CRT in patients with medically refractory atrial fibrillation and heart failure. Thank you very much for participating in this program.